Well, thank you everyone for joining us today on this webinar to review the results of the 2019 Access to Behavioral Health Care in Michigan study. My name is Becky Cienki, and I'm the Director of Behavioral Health here at the Michigan Health Endowment Fund. For those of you who aren't familiar with the Health Fund, the Michigan Health Endowment Fund is a philanthropic organization in Michigan aimed at improving the health of Michigan residents. We have a special emphasis on the health and wellness of children and seniors. This study is part of the portfolio of our behavioral health initiative here at the Health Fund. In that work, we do grant making through a pretty predictable request for proposals that comes out every February with awards made in August. We also have a number of contractual projects where we examine opportunities to continue to improve access in Michigan and are providing education to our grantees and other partners. We look forward to many opportunities to continue to collaborate throughout the state. I thought I'd share a few. The primary goal of the Behavioral Health Initiative really is aimed to improve access to behavioral health services, including mental health and substance use services here in Michigan. A couple of the priority areas we support through that work are implementation of innovative care delivery models, multi-sector responses, really aimed at strengthening local systems of care and getting people into care. We're focused on use of innovative technology as a mechanism for improving access and quality care, the use of team-based approaches to care, and of course, strategies aimed at improving health equity. I am really excited that you've joined us today to hear the 2022 update of the Behavioral Health Access Study. This uses 2019 claims data that Ani and Corey will share more with you shortly. I'm really excited about the opportunity this provides us in terms of having a bit of a baseline. The first study, some of you may recall, was done and released in 2019 with 2016 claims data. This is an examination of 2019 claims data, and then we'll look forward to another release with 2022 claims data. So it allows us to get a good baseline pre-pandemic and then to examine further the impact with 2022 claims. This study also allowed us to examine some subpopulations, which we hadn't dug into in prior years, including the Medicaid fee-for-service population, pregnant and postpartum women, children in foster care, and also a further examination of medication for opioid use disorder treatment. So you'll note that there continue to be opportunities to improve access. We did see some modest improvements worth celebrating. So at this point, it's my pleasure to introduce to you Ani Turner and Corey Ryan from Altarum, who will take it from here.
Wonderful. Thank you, Becky. Thanks for the introduction and the opportunity to do this work. And we're very excited to share our findings with you today. As Becky mentioned, this work is all based in a large report that's also been published on our website and the Health Endowment Fund website. So we'll go through a lot of the highlights today, but there's lots of additional details in that report. So hopefully everybody will go out and view that as well. I will see if I can get the slide to advance here. There we go. Hi, I'm Corey Ryan. I'm a research director in the Health Economics and Policy team at Altarum Institute. Altarum Institute is a nonprofit research and consulting institute headquartered in Ann Arbor, Michigan. I've been working there for about 7 years. My background is in economics and public policy, and I've been doing a variety of research around health, healthcare access, social determinants of health, and health spending tracking with Ani for that time period.
Hi, everybody. I'm Ani Turner. I am director of the Health Economics and Policy Program area at Altarum, and I've been an economics and math background, and I have been studying issues in healthcare, access and quality and cost and spending and workforce for more than 30 years. And Corey and I teamed up on the original analysis of behavioral health access in Michigan, and again on this update. So we'll be sharing the presentation with you this afternoon.
Fantastic. Thanks, Ani. And I also want to note that there are two other report authors that are not on the call with us today, or might be listening on the call today, Matt Daly and Danielle Hurdle-Robb. We thank them for their excellent research assistance and a couple other folks that also contributed to this. So Ani and I are presenting, but this is a whole team project that was really put together at the group at Altarum. So we just did introductions. I'm going to spend a little bit of time today setting the stage, talking through a little bit of the underlying goals and objectives that we had in doing this refresh. So again, this is a refresh of our assessment of access to behavioral health care within the state of Michigan, updating numbers from 2016 data to 2019 data, using a lot of the similar approaches that we did in the past, but trying to get a better understanding of where progress has been made within the state over this time period, and trying to, again, as Becky mentioned, drill in on a couple of very interesting subpopulations that gave us better understanding of some really important needs for those different groups across the state. So I'm going to talk a little bit about the data and the details, and then we'll dive right into the results after that. So the overall objective of this work is to assess access to behavioral health care in Michigan and try and provide a really strong baseline in understanding what access to mental health and substance use disorder care in Michigan looked like prior to the COVID-19 pandemic. So when we started doing this work, we were already into the pandemic, and we know that that has very, very drastic impacts on both the need for behavioral health care services in the state and also the underlying delivery system that was providing those behavioral health care services. But 2019 data were the most recent available when we started this, and I think will provide a really good understanding of what was going on in the state and what progress was made from 2016 to 2019, and how that will then impact our assessment of the state's behavioral health care system going into the 2019 pandemic going forward, as Becky mentioned. And so we really wanted to do this follow-on study in a way that matched the underlying data and matched the underlying approach that was used to generate the 2016 number. So that way we could compare 2019 results to 2016 results, and where we saw improvements, where we saw things stay the same, or even in some cases where we saw things get worse over that time period, and what that meant across different geographic regions, across different populations, across different statuses of insurance, really across a lot of different dimensions, and trying to look at access to behavioral health care. So when we do this study, we first define behavioral health care to include mental illness and substance use disorder treatment. So we're looking at the combination of both of those needs. And we're looking at both mild to moderate mental illness and serious mental illness needs. Those are generally combined together into our mental illness estimates. And then substance use disorder as a separate category. Within those two groups, you have co-occurring conditions where folks can either have multiple needs across those two categories. We don't look specifically at the co-occurring condition population, so we're not assessing access for those with both needs directly. We're looking at those groups as they exist within the mental illness and the substance use disorder population, but those populations certainly do overlap and can result in co-occurring conditions at the same time. When we're looking at what behavioral health care services mean, we're including outpatient services, we're including intensive outpatient services and residential services in that. So what's not included in that would be inpatient services, directly looking for what it means to have access to that care. So we're looking primarily on the outpatient side of the issue, as far as the types of care that are being provided and whether folks are receiving care for their behavioral health care needs over this time period. Outside the scope of the study also includes those with intellectual and developmental disabilities. We're not specifically looking at those conditions in this study. Again, if individuals have a mild to moderate mental illness, they would still be included, even if they had intellectual or developmental disabilities. We're just not specifically looking at the access to and delivery of treatment for those conditions. As I mentioned, we're not including inpatient psych services or chronic pain treatment in our definitions of receiving care. And we're also not including assessments of supportive services, which is a really critical component in helping those that have mental illness and substance use disorder needs have a complete continuum of care. However, we're not assessing directly access to those treatment options or kind of services within this study. So our approach in the study, which is again consistent for those that were familiar with the work we did in 2016, was to first try and quantify the number of individuals that needed care for mental illness and substance use disorder within the state. We do that by using survey data. So we're using data from the National Survey on Drug Use and Health that assesses the prevalence of mental illness and substance use disorders within the state, and then apply those prevalence rates across different population types. So across different age groups, across different coverage types of insurance, across different conditions, applying those information to then the population data within Michigan to generate estimates of those that would need care for any mental illness or substance use disorder within the year. So by multiplying the population data by the prevalence data, we get an estimate of those that actually need services over a period of time. And then we use the claims data, which actually records medical services that are being provided, to assess the proportion of those that we expect had these conditions that actually received care over this time period. And again, we do that by breaking down care received across different payer types, across different age and sex mix, across different races, and across different conditions and geographic locations. And we'll show a lot of that detail in the results of the study, and lots of detail in the report there as well. So using that kind of difference between the expected need and the observed use of care, it's really important that the way that we define those that receive care based on the claims data is a really, really basic measure of access. So treatment for behavioral health care needs can be very complex and require very extensive and long-term treatment. We're not capturing the extent to which individuals received their complete need of treatment, or the extent to which individuals received the highest quality treatment that they could have received for their care. We're just looking at a basic measure of access to try and identify, were individuals able to get their foot in the door to the behavioral healthcare system and be treated at least once for either their mental illness or their substance use disorder need. So there's a whole other kind of additional line of work that could be done around the quality of care that folks are receiving. We're just looking at a basic measure of access. And unfortunately, what you'll see is, even just based on a very basic measure of access, you have a lot of individuals within the state of Michigan that are not receiving any care within a year for their mental illness or their substance use disorder needs. Just a quick note on some of the underlying data sources. There's a whole methodology appendix in the report that I will point folks to that are interested in kind of having a greater understanding on how we do this work. But you can just see at the top here, again, the two surveys that I mentioned, the National Survey on Drug Use and Health and the National Survey on Children's Health, that we use to identify the prevalence of any mental illness and substance use disorders. And then you can see at the bottom the list of the claims data that we use to observe those that are actually receiving care. And this includes private insurance claims, Medicare claims, Medicaid claims, and also Medicare Advantage claims as well. So let's jump into the findings. And I'll start with just kind of the top level findings comparing 2016 to 2019, and then we'll drill into some more details as we go through. So between 2016 and 2019, what we observed is that the prevalence of behavioral health conditions, and particularly the prevalence of any mental illness in Michigan, increased. But there was also an increase in the number of providers providing care, and therefore we saw the number of individuals receiving care for mental illness and substance use disorder also went up in Michigan between 2016 and 2019. And so while the number of individuals receiving care increased because the need increased as well, you were left with still a very significant number of Michiganders that still had unmet needs for any mental illness and unmet need for substance use disorder care. So you can see about 600,000 with any mental illness that did not receive care at all in 2019, and 400,000 of those with a substance use disorder who also did not receive care. And so where this sets us is that we did see some improvement, but the problem is that because the underlying prevalence of a lot of these conditions is increasing over time, and we expect that unfortunately continued into 2020 and into the COVID-19 pandemic era, you continue to have challenges around providing complete care for those and providing complete access for those to receive treatment within the state of Michigan. And we note here that that is an issue both in increases in prevalence and also healthcare workforce shortages that occurred over that time. So we'll be interested in certainly comparing these trends that we see from 2016 onto 2019 and then into the 2022 period, as Becky mentioned, in the future. Just to set the stage a little bit, this is the map showing where Michigan sits relative to other states in its prevalence of any mental illness in 2019. You can see Michigan there falls about the middle in its overall prevalence. This is looking at adults only, relative to other states as far as the prevalence of mental illness needs within the state. And you can see down in the bottom right there, the trend looking over the period from 2009 through 2019. And you can see in 2016, we were actually in a period of a slightly lower overall prevalence within the state of mental illness needs, and that increased slightly all the way up through the 2019 period, which was the study that we're just reporting on now. So I'm going to show you a handful of charts here that basically detail the extent to which different categories of individuals within Michigan were able to receive care for mental illness. And so you can see on the left is our 2019 data, and on the right is our 2016 data. And these pie charts show in green the number of individuals and the proportion of individuals that received care for mental illness, and the blue being those remaining that were untreated within the year or had an access gap or were unable to receive care for mental illness and then also substance use disorder. So you can see a slight improvement here in that the gap closed from 38% of those in 2016 being untreated for any mental illness down to 32%. What I'll note is that we're not adjusting the size of the pie charts here, but the number of individuals in 2019 actually increased. So the number of individuals receiving care increased from just over 1 million to 1.3 million. So a lot more individuals receiving care, but the number left untreated actually really didn't change that much. And again, that's to the point that we were making earlier, where the overall prevalence of mental illness increased within the state over this time period. And therefore, even though the number receiving care increased, that access gap did not close as much as we would have otherwise seen as a result of that increased prevalence. And this generally holds as a finding across a lot of the populations and a lot of the conditions that we looked at in this study. This is then breaking down that group, and I'm going to show you 3 different charts here across different payer types. So this is first looking at Medicaid. So you see the need, the relative need and the relative share untreated among Medicaid in 2019 also improved a little bit from 2016, but the overall share of Medicaid recipients being untreated for mental illness conditions is greater in proportion relative to the state average. So Medicaid folks are receiving less care for their mental illness needs as a proportion of those that we expect would have needed care compared to the population as a whole. So a little bit of improvement here, but still 220,000 of those Medicaid enrollees in 2019 that were untreated for mental illness in 2019. Here you can compare that to then the Medicare population, and you can see that the rates among Medicare in getting treatment for mental illness are much higher. So about 88% of those in 2019 with Medicare coverage, an improvement from what we saw in 2016, were able to receive care for mental illness, leaving only about 35,000 or about 12% of those in 2019 that were untreated for any mental illness. So a much higher rate of treatment among Medicare enrollees relative to Medicaid enrollees. There's also a much higher prevalence in total among the Medicaid population, and we'll drill in a little bit to, in some future slides to look at how the rates of care being received compare across different age and sex mixes as well. And of course, Medicare and Medicaid, while they have some overlap, look very different in their overall distribution of enrollees. Here, then you can see where the privately insured population fits, and they fall somewhat between the Medicaid and the Medicare group. And again, here you're seeing a little bit of an improvement from 2016 to 2019. You're seeing we're going from 66% of those in the privately insured population up to 71% receiving treatment, and also an increase in the true number of those receiving treatment for mental illness in Michigan over this time period, up from an estimated about 580,000 up to about 750,000. But despite the fact that we had an increase in the proportion of the total numbers receiving care, particularly among the privately insured population, again, we saw that increase in prevalence of mental illness needs within the state. And so that number untreated remained almost about the same, falling just very slightly from about 305,000 down to 300,000. So again, this increased need, you have more folks receiving care in Michigan between these two periods, but because need is increasing, there still remains a very significant untreated population. Those that are falling into the access gap, we'll talk later in this presentation about what some of those reasons might be of why individuals are not able to receive care, but a significant number of folks still not receiving treatment for mental illness. So I'm going to flip over now from mental illness specifically to substance use disorder. Again, you can see Michigan falls about the middle of the country relative to other states as far as its prevalence of substance use disorder conditions in 2019. And you can see there just in the trend over time from 2015 through 2019, holding relatively constant, and then not a whole lot of change in substance use disorder needs over this period. We do know in kind of future looking data that the need for substance use disorder treatment has increased going into 2020 and onward, as unfortunately we saw greater levels of drug use during the COVID-19 pandemic and following on. Here then we show just again the breakout of those that received care versus those that were untreated for substance use disorder needs. And the big thing I want to point out here is the difference between substance use disorder needs and any mental illness needs as far as the share of population receiving treatment. And consistently what we see is there is a greater proportion of individuals with substance use disorder conditions that are not receiving any treatment throughout the year. So this is between 2/3 and 3/4 in 2019 of the population of those with substance use disorder needs not receiving any care. It's about 420,000 individuals in 2019 that did not receive any treatment. So that's a much higher rate. So it's a lower population proportion of those that have substance use disorder conditions relative to those that have any mental illness. Mental illness is more common, But as far as the share of those actually receiving treatment, the share of those receiving treatment is much, much lower among the substance use disorder population. Again, you can see a little bit of an improvement here, an increase from about 20% to about 28% of those receiving treatment. But again, it's still a very significant population that remained untreated in 2019. Here you can see the change and the difference among the Medicaid enrollees. So you can see an increase here, a significant bump up in those that were receiving care in 2019 relative to 2016, although again, still a very large population that was untreated in 2019. There was a small difference in the 2016 versus 2019 Medicaid data. So a little bit of this difference might be driven by the data that we had available to us when we did this analysis. But we expect that there was some true improvement in the overall rate of those receiving treatment over this time period as well. But again, still about 59,000 individuals remaining untreated with Medicaid coverage for their substance use disorder conditions in 2019. Here you can see the rate among Medicare in substance use disorder treatment. Medicare and Medicaid look more similar as far as the share receiving care versus untreated. The rates of substance use disorders among Medicare enrollees are relatively low, but again, still a significant population there. On the left-hand side, you can see over 30,000 Medicare enrollees in 2019 not receiving treatment for a substance use disorder condition. And then lastly, here you can see among the privately insured population, you can see the rates of treatment, those receiving care are very low compared to the two publicly insured populations. So you can see the rate of treatment in 2019 for those with private insurance is only about 15%, leaving about 280,000 individuals estimated with private insurance who are not receiving treatment for substance use disorder care. Our claims data that we have, our private insurance data, do not include data on those that would have received treatment through, for example, employee assistance programs. So we might be missing a little bit of that treatment that's being provided. Or if individuals are going out and paying for their substance use disorder treatment directly, we also would not observe that in claims. But even with those caveats, I think it's still very true that unfortunately, there's a huge level of unmet need for those among the privately insured population to find access to substance use disorder treatment. So now I'm going to take a sec to kind of break those findings down. That's the high level findings across the different payer groups, to break those findings down across different payer types, across different conditions and different demographic groups as well. So you can see here sitting side by side, the prevalence of mental illness treatment and the rate untreated in 2019 across the 5 different payer types. You can see that the way that these bar charts are written is that the green bars are the proportion of, or the number of those per population that were receiving care. So the height of the green bar is the share of those of the population that received treatment, and then the total height of the bar is the total prevalence. So you can look at the total height of the bar here and see that among the Medicaid population, mental illness prevalence is highest. And then you can see the percentages which show the share of that population that remained untreated relative to the percentage of those that were receiving care. So the uninsured population as a share of its population has the highest rates of unmet need for mental illness. And then you can see the share of treatment that was being provided was also the lowest among that population. Medicaid having a high share of those receiving treatment, but an even higher level of unmet need relative to private insurance and relative to Medicare and other insurance populations. You can contrast then against the SUD population. And while the rates of substance use disorder conditions are much lower across all these different insurance types, you can see the scale on the left has gone from being in the 200 to 300 range down to the less than 100 range. But you can see that the share of these bars, the blue section, those that were untreated over this time period, is much higher. In Medicaid, again, you can see the overall height of the green bar, the percentage of those receiving care is highest among all the groups, but still a very significant proportion remaining untreated. And as I mentioned before, uninsured and private insurance populations have very high levels of unmet need for substance use disorder care as well. And then you can look on the right and see the overall rates of substance use disorder among Medicare enrollees is somewhat lower, and also that their share in being treated is more average or a little bit better than certainly than those in the other insurance categories. What we then do is then we can also break out within these insurance categories and look at the rate of treatment among those with different types of coverage. So within the private insurance population, we can look at the type of healthcare plan that they have. Within Medicare, we can compare Medicare between fee-for-service and Medicare Advantage. And within Medicaid, we can compare those that were enrolled in an MCO versus those that were not enrolled in an MCO. And you can see among these groups, we're not able, because we don't know the actual underlying prevalence differences across these different categories, what the overall need was, but we can show, which is what we're showing here, the rate of those receiving care. And what you see is a lot of patterns that you might expect. Let's start with the private insurance. You can see that those that are in an HMO or a PPO plan do far better as far as their rate of receiving care for mental illness than those that are in a high deductible plan. And for those that know, high deductible plans are likely putting up greater cost barriers to receiving treatment because of the higher deductible and the higher cost sharing that might be expected for those that would need care. And therefore, that is showing up here as resulting in folks receiving less care among private insurance relative to those with the more traditional HMO or PPO plans. Among Medicare, again, a similar story, in that those within the fee-for-service population, where access is generally better and cost sharing can be lower relative to Medicare Advantage, you're seeing higher rates of those going out and getting treatment for mental illness. Some of that may also be driven by differences in the population that falls within these insurance types. So the fee-for-service population is traditionally known to be a little bit sicker, have higher rates of chronic conditions. Those also may be associated with higher rates of mental illness needs. So some of that higher utilization within the fee-for-service population may be a result of the fact that there's higher needs among that group. But we certainly, what we can say is that we can say that there is certainly higher levels of treatment among that population relative to Medicare Advantage. Again, a similar story in the Medicaid population, where you have the MCO enrolled population versus the non-MCO enrolled population. We're actually seeing higher rates of mental illness treatment among the non-MCO population. And we think part of that might be due to differences in who is included and who gets enrolled in an MCO versus who was carved out in Michigan and left not enrolled in an MCO. So you see higher rates of mental illness treatment among the non-MCO population, but a lot of that is probably driven by differences in the population. Here again is the same chart looking at the rate of substance use disorder treatment. Again, within the private insurance population, you have higher rates of treatment among the HMO and the PPO type plans versus a high deductible plan. That again is likely showing that cost is a driving factor of why individuals are not receiving care. Because those plans with higher deductibles and greater cost sharing are receiving less treatment over time. Similar story again in Medicare, where you're seeing higher rates of treatment among the fee-for-service population versus the Medicare Advantage. We expect that's driven both by cost issues and also access issues, as within the fee-for-service population, you don't have the same network restrictions that you might have depending on what your Medicare Advantage plan is in the Medicare population. And then among Medicaid, again, higher rates of treatment in the non-MCO versus the MCO population. A lot of that we think is driven by differences in the population of individuals that fall within those different categories. Here then is just breaking out with more detail within what's going on within the Michigan Medicaid population, the coverage of those that are receiving care from a prepaid inpatient health plan versus those that are receiving treatment across different conditions for those that were receiving care either by an MCO or in the fee-for-service environment. So you can see here the split of those across different conditions of those that received care by a PIHP versus those that did not have a PIHP plan, even if they received care. And the spread that you see here is what we would expect, in that because of the responsibility for the PIHPs to cover substance use disorder care, you see higher percentages of those receiving care for a SUD condition, the list down at the bottom, particularly opioid use disorder, at a very high percentage of those individuals receiving care getting it through the PIHP, versus among the mental illness population, you see somewhat surprisingly, there's a very high proportion of individuals that are receiving care, but they're not receiving it through a PIHP. They're receiving it either through the MCO directly, or they're receiving it again in the fee-for-service setting. And so I think this is an interesting finding in the level of treatment within the Michigan Medicaid population that's occurring outside of the PIHP structure. And particularly for mental illness and mild to moderate mental illness, the fact that a lot of those conditions, something like single depressive episode or something like mood disorders that can tend to be more of a mild mental illness condition, the fact that 83 and 89% of those conditions are being treated again outside of the PIHP realm. So here is, again, using that additional condition data that we have to look at the prevalence and unmet need of mental illness conditions, and looking at the rate of those receiving care versus those that are untreated. And what we see is that for conditions, again, that can tend to be, they don't have to be, but they can be more mild to moderate conditions, such as single depressive episode, anxiety disorders, mood disorders. Those tend to be examples of conditions for which you have higher levels of untreated individuals, or those that are falling into the access gap. So more serious mental illness, things like bipolar disorder, recurrent depression, are treated at a higher rate. We see a greater percentage of those receiving care relative to some of the other categories of mental illness. And so what this tells us is that those that are not receiving treatment for some of these more mild to moderate conditions may be, again, because it may be related to cost issues, it may be related to individuals simply not seeking out care within that year for that condition. So the highest rates of unmet need are actually among some of the more mild to moderate mental health conditions. But of course, any of these conditions can spread across mild all the way to serious. And so this is just looking at kind of the correlation across these different types of mental illness and the rates in care that we observed. Here's then that same chart looking at substance use disorder conditions. And what you see is, again, the overall rate of different substance use disorder needs, the highest prevalence being alcohol use disorder and cannabis use disorder, then followed by opioid use disorder. Other substance use disorders were kind of too rare within our data set to be able to parse out specifically, so we just focus on these top three. And again, you can see the highest rates in lack of treatment were for alcohol use disorder, and also the highest prevalence were for alcohol use disorder, versus opioid use disorder, which actually only had about 23% of the population prevalence that we looked at that were untreated. Although when you look at the actual quality of care that those with opioid use disorder received, and we do this in a couple different ways in the report, but I show here on the right a statistic of the percentage of those with opioid use disorder that actually received medication-assisted treatment. So the gold standard of treatment for opioid use disorder was only about 31%. So that's basically the proportion of that green bar of those that actually received the gold standard of treatment was only about 31%. This is above the national average, but still significant room for improvement in the fact that those with opioid use disorder, while they're receiving treatment, are not yet receiving that gold standard, and more progress that needs to be made there. Here's breaking out the total need for any mental illness across the state by age and sex. So you can see the difference in prevalence again in the total height of the bar, and then the percentages shown as the percentage of those within the height of each bar that remained untreated among the different groups. And so you can see for mental illness, the highest levels of need are for adolescent and young adult females. And then those are also the two groups with the highest percentage, the highest level of unmet need for mental illness care within the period of 2019. You can then see then for older adults, the rates of mental illness go down, and actually the proportion of those receiving treatment goes up. So really identifying a need here for that young adult population and mental illness treatment in 2019. A rather similar story for substance use disorder. Again, you can see actually among young adult males is actually where you have the highest rates of substance use disorder. And again, also some of the highest rates of not receiving treatment for substance use disorder care. What we see for substance use disorder care is these rates of untreated among the different population and geographic groups is actually more consistent. So it's consistently low rates of treatment across a lot of different groups for substance use disorder care. Any mental illness tends to be treated a little bit more, tends to have more variation across the different age, sex, and geographic groupings, whereas substance use disorder care really has high levels of needs across all different groups. Again, very different rates of needs across these different populations, but the overall percentages are more consistent for substance use disorder care. Here you can see a split of looking at the difference prevalence and the difference in treatment rates across different race and ethnicities in 2019. You can see on the left the rates of any mental illness treatment among different groups. And then you can see on right the comparison of the overall prevalence, the overall utilization of treatment in the white versus the non-white populations. And so when you look at the percentages in the chart on the left, you can see that across different groupings, Black and African-American individuals actually have the lowest rate of untreated any mental illness, but that's also because their prevalence is not as high. And so while whites have a higher overall rate of treatment, they have a much higher rate of prevalence need for mental illness care as well. And so there still are very significant disparities when you look at the difference between the Black and the white population, or the white and the non-white population, in the height of those green bars, in the height of those who are actually receiving care. There's a very significant level of disparity. It's just that when you also account for the overall prevalence of these conditions, what you see is that it's a much more kind of comparative look as far as the share of those that are not receiving treatment. But again, showing on the right, very significant disparities, unfortunately, between white and non-white populations as far as those that are actually receiving treatment for mental illness within Michigan. Here again is the same chart for substance use disorder. Again, a very similar story here. The prevalence rate among the white versus the non-white populations is higher. The white population is receiving significantly higher rates of treatment for these conditions. And therefore, and this occurs across all the different substance use disorder conditions that we looked at specifically in this report. Here again is, this is for the first time, again, looking at the geographic split in basically the rates of any mental illness need and treatment across different metropolitan areas within the state of Michigan. As I mentioned, there is some significant variability in mental illness treatment across different geographic areas. Looking, for example, here you can see the Detroit MSA with one of the highest rates of untreatment of unmet need for mental illness, about 45% of that population, versus in some of the better parts of the state, you can see mental illness treatment rates closer to covering 80% of the population, leaving only about 20% untreated for mental illness care. This is the same chart for substance use disorder, much higher rates of unmet need for substance use disorder, and much more consistent levels of unmet need for substance use disorder across the state, leading to this, again, higher percentage and more consistent rates of unmet need for substance use disorder care. There's more charts kind of breaking this down in the report, but wanted to give you a high-level sense of what we had available and what we've produced in this work. So all of this, of course, begs the question of, okay, we have very significant levels of unmet need. Why are individuals within Michigan not able to receive care? And we didn't update this work in this 2019 study, but when we looked back at the 2016 study, we expect a lot of the same reasons for those not receiving care in 2016 continued into 2019. You can see here the top ones listed. When you go out and you ask individuals, why did you not receive treatment for any mental illness or substance use disorder care? The things that bubble to the top are the fact that they couldn't afford the cost of receiving care. They didn't want to get treatment. They weren't ready to get treatment for their conditions. They didn't know where to go. They didn't have time. They didn't have the proper insurance coverage, or they didn't want others to find out about their condition, unfortunately. So some of these reasons are related to folks that would like to get care but can't get care for a variety of reasons. And some of these issues are around individuals who are simply not ready to get treatment for their condition that they have at the moment. So this really shows that there's a wide range of reasons for why individuals are not able to get access to care within Michigan. And it's going to take a multi-pronged policy approach in order to help folks find access to care over time. Ani, I think I'm going to turn it over here to just start talking about provider supply.
Yeah, thank you. So again, in our original study, we really dug into barriers to care. And as Corey said, there are a variety of types of barriers to access to care. But one of the things that we wanted to update in this data refresh is taking a look at the supply of behavioral health providers across the state. And what we can see is, so this chart is obviously showing county level data, and the darker the shading, the scarcer the supply, essentially, the more people per provider. And again, similar to what we saw in the 2016 based data, the northern part of the Lower Peninsula, parts of the Upper Peninsula have contiguous kind of areas where there is a shortage of providers. But overall, we see the population to provider ratio went down. In other words, the number of providers went up relative to the population between 2016 and 2019, and on the order of 25%. And now this was actually consistent with what was seen in other parts of the country as well, but it is, it is a cause for celebration that we do see an increase. And these numbers represent all types of behavioral health providers, psychiatrists, psychologists, social workers, various types of therapists, et cetera, relative to the population. Next slide, Corey. So these two maps of Michigan are really honing in on areas where there really is a significant gap in numbers of providers. And in particular, where there's orange is an indication that there are no providers of a particular type. On the left, that map is looking at numbers of psychiatrists or psychologists. And any county that's shaded in orange has neither a psychiatrist nor a psychologist practicing in that county. The counties that are shaded in the tan color are missing one or the other of that provider type. And then on the right, this is a map of Michigan showing substance use disorder treatment facilities. And again, those counties shaded in orange have no substance use disorder treatment facility. And those that are shaded in tan have a lower relative to the population. So we have 5 counties overall in the state that have neither a psychiatrist nor a psychologist nor a substance use treatment facility. There are 9 counties, again, with neither a psychiatrist nor a psychologist. And you can, again, see the parts of the state where there are large geographic areas with a real lack of provider supply. Next slide. So, Corey showed you the variation in access by metropolitan area, and we've looked at provider supply. So we know that across the state, some parts of the state have better access than others. No one has complete access. And we know, again, there are a variety of reasons why people are not receiving care for conditions. Some being access to the system or financial reasons, and some being related to willingness to receive care and concerns about stigma. But we wanted to provide some numbers, again, an updated version of numbers that we provided in our original study that look at perhaps a more feasible goal for the state in terms of improving access. And this, what we're characterizing this as is, what if throughout the state of Michigan, we could achieve the same level of access in all of the state as we do in the best access parts of the state? So what if we could more equalize and kind of raise up those areas where there's a lack of providers or other barriers to care? And the orange parts of the pie here are showing us if we could improve access throughout the state to the best access areas, how many more people would be treated, what greater share of people would be treated for a mental illness or a substance use disorder. And you can see, if you, again, raise to the best access across the whole state, then another 17% of those with a mental illness would be receiving care, bringing the total up to 85%. And similarly for substance use disorder, more than 40% of those with a condition, if we could equalize access to the highest level across the state, would be receiving care. And these represent an improvement over what a similar chart that we showed in the 2016, where it was closer to 75% with full access, with the best access, and more like a third for substance use disorder with full access. So I want to quickly, I want to leave room for questions, but I want to quickly just talk you through and identify, as Becky mentioned, that we did drill into some additional dimensions in the data, in this data refresh compared to in the 2016 data. One of the things that we looked at and provide in the report is a breakdown of place of service by payer type. And I think I won't go into all of these numbers, but one thing I will draw your attention to in one of the rows toward the bottom there is the telehealth line. We wanted to, again, get a pre-pandemic baseline measure of the degree to which the services that we're seeing provided were provided by telehealth. And you can see in 2019, it was less than 1%. And now we expect, and in talking with other researchers, believe that that number went way up in 2020 and beyond, and we'll see where it levels out. But I think it's interesting to see how low it was as of 2019. Next slide, Corey. And then similarly for substance use disorder treatment, again, even lower percentages of telehealth. You can see it, that row there on the bottom. So again, in the report, we provide this breakdown of place of service for both mental illness and substance use disorder by payer type. And then we also wanted to drill down with, go ahead, next slide, Corey, with the data that we had with the claims data that we were using for our analysis, and provide what I would characterize as just an initial look at behavioral health services being received by several populations of interest. The first being women who were pregnant or gave birth in calendar year 2019. And here we're looking at treatment for mental health conditions or substance use disorders. The share of these pregnant women who met our criteria for either giving birth or being pregnant during the year, and the share of receiving treatment for these conditions under Medicaid and under private insurance. And you can see about 28% of Medicaid pregnant women or women who gave birth were treated for a mental health condition, similar percent under private insurance. And under substance use disorder, a little higher percent under the Medicaid population of 11% and about 2% for private insurance. Next slide. We also looked at screening for depression, again, for our pregnant women, and found that a little over 26% of pregnant women showed evidence in the claims data for screening for depression. And again, 45% under private insurance showed evidence of screening for depression in the claims data during calendar year 2019. We also looked, again, very initially at treatment of children in the foster care system who are eligible for Medicaid in our Medicaid data, and looked at the share being treated for mental illness or substance use disorder. And again, this is just showing the share of children under Medicaid in foster care who received treatment. About 38% received treatment in calendar year 2019 for any mental illness. And the disorders that were predominant were PTSD, stress disorders, and ADHD and related disorders. And again, small numbers for substance use disorder. Next slide, Corey. Okay, I think we're going to have some time for some questions, and I see there's a number already in the Q&A, but wanted to conclude with, again, this is bringing back from our original comprehensive study of access to care. We talked about barriers to care being related to actual supply and availability of providers, affordability concerns, willingness to seek care. And in our original study, we identified a number of ways, and I think many of these are things that the Health Fund has been supporting to increase the supply and the effective supply of providers, whether through telemedicine or innovative technologies, integration of behavioral health and primary care. And then, of course, there are challenges with affordability and with willingness to seek care. And so we see some evidence of progress being made between 2016 and 2019. And we know that there was a significant disruption to many of these factors and to prevalence 2020 and beyond. So we will be very eager to see how this all played out when those data are available in a few years. So I know we have a number of questions that I think many of which I think we can address. Yeah, Becky,
Thank you. I'll give you a quick second to take a break on you, Corey. Okay. Thank you so much for the remarkable presentation. And I see that Corey has been providing responses to a number of the questions already. So feel free to identify those or look at those in the chat. I also wanted to thank Sarah and those who've messaged me regarding the clarification that this was specific to the slide that identified MCOs and PIHPs and who paid for which piece. That priority under the mental health code is that PIHPs are responsible for serious and severe mental illness and not mild to moderate. The complexity of that gets a lot of individuals confused throughout the state. We wanted to provide clarification and excitement over the expansion of the CCBHC model, which really does extend opportunity for our mental health partners in the public sector to serve additional individuals. I will turn it back to you to answer some of the additional questions, if you don't mind.
Yeah. All right, Corey, a lot of these, you starting from the top, are kind of methodological. So maybe we want to start with some of those questions.
Yep, and I tried to take a couple of easy ones and answer them in the chat. Becky, thank you for that clarification around the PHPs. Yes, and I think it would be a really interesting analysis to drill down into the level of access for serious mental illness versus mild to moderate mental illness. We tried to do this in the prior report, if you remember. It's very difficult to identify within claims data, which typically just use a diagnosis code, of whether or not an individual is needing care for mild to moderate mental illness within these mental illness conditions or serious mental illness within the same categories. So I think it's still an area of kind of open research and trying to get a better understanding of how that care is being received across those different categories of mental illness, even within the conditions that we had. So let's see here. Stacy asks, are these folks who didn't have treatment or did they seek it, or is it unknown? Yeah, so this is an unknown, Stacy, and I think we talked a little bit about this later in the presentation around the fact that we're just identifying folks who did not receive treatment. The reason why they did not see treatment could be because they sought it out and either couldn't get it paid for, couldn't find the right provider, didn't have access to the right provider, didn't have coverage for the right provider, or it could be that they did not seek it in the first place. So it's a combination of both individuals there. Bob is asking, and a couple questions here around schizophrenia. That was included in the entire list of mental illness conditions. I don't believe we separately carved it out as a particular condition that we assessed as the rate like we did for the other conditions. So it is included in one of them. And I'm so sorry because I don't know which one it was included in. I'll take that one offline. The detail is certainly in the report too of which category it falls into. And so it is included in the total numbers that those with schizophrenia are included in the mental illness, both in those that need care and also those that received care. It's just not separately called out as a condition that we identified the separate rate for. And what grouping it's in, I apologize, I can't remember right now, but I'll be able to find it. I think that covers those two. Question by Drew here around, is there a way to drill into the 0 to 17 age group to see if where the untreated are in different age groupings? That would be theoretically possible. We did not do it. I would say the one limitation is most of the prevalence data that we have begins surveying at age 12. And so you're going to miss those younger populations because we only have the prevalence understanding for those from the 12 to 17 grouping. So we could do age groups within that range. We could also look among those receiving care to look at the utilization rates across the different age groups. So we could look even all the way down to very young age groups to see those that were receiving treatment. But I totally agree. This is a very important area of study, and particularly around providing school-based care is an area that we looked at that was in the list of that Ani had of the settings of care that individuals can receive care. And I think doing a better job in trying to parse out those age groupings is something that we could do. So maybe that's something to pencil in for a future analysis, Becky.
You know, and I think, there are various groups that look at ratio of students to psychologists compared to recommendations. And I think we have improved over the last few years. We've improved since 2016 on that, but we're still kind of at or below average in terms of the supply of school-based psychologists relative to the student population.
Question here from Pamela around the difference in prevalence rates for people of color versus whites. Yeah, a great question. So we are basing this data based on responses to surveys. So the National Survey on Drug Use and Health is going out and asking individuals through a structured survey process around issues of mental illness and around issues of substance use disorder treatment. So lack of diagnosis wouldn't necessarily be an explanation for the differences that we're observing, but differences in the way that folks are responding to the surveys could be a factor here. And we think there could be some response bias in the way that maybe whites are more willing to report that they have mental illness or substance use disorder needs relative to people of color and non-whites. That is going to show up as whites having a higher prevalence, a higher need, and a higher rate of unmet need relative to those other groupings. So I think we're really kind of dependent on those surveys because they are really high quality surveys and going out and trying to understand the need for these conditions across different groups. But I think better understanding how folks are responding to those questions over time is a potential source of error and is also, a really important consideration as we're trying to get a better understanding of mental illness and substance use disorder needs. Ani, I see a couple of things around providers. Can you answer a couple of those?
Yeah, so with regard to the counts of psychiatrists and psychologists, these data come from National Provider Identifier data in terms of counting the numbers of providers by county. And again, remember, we're showing 2016 versus 2019 data. So the situation may have changed since then. The question is community mental health, included? I don't know why it would be excluded. But this is something that I can look into further and see if I can get some clarification. So again, where we're looking for counting numbers of providers by geographic location in practice is from the National Provider Identifier Database. And I would guess that those practicing in community mental health would be part of that, so they can bill the government for care received. Yeah.
Great. Christine, yep, thank you for the note on the PHPs. And yes, the PHPs are managed care. So when I say MCO, I'm talking about the traditional, that is unclear language on my part. I apologize. MCOs, when I use that language, are the traditional health plan MCOs in Michigan. I understand the PHPs are managed care. Those are included outside of that. So the three categories that we have within Michigan Medicaid in our study that we're looking at are the traditional health plan MCOs, the PHPs, and then also the fee-for-service population. So when you read the report, those will be the three distinctions that you'll see when you look at the rates of care being provided across the different categories.
All right, and if you want to, these slides will be made available, by the way, and we do have contact information in the last slide, as well as a link to the report. And I'm seeing Bob Sheehan is asking about social workers in particular. Again, one of those maps did include social workers among the range of mental health behavioral health providers but we didn't break it out specifically. The data source that we used there combined all behavioral health care providers by county, which is what we then reported in the map. It's certainly possible to break that out. Yeah, so that's something that we can look into further. I see. So again, some clarification here I'm seeing regarding if MPI is what is used, related to where care is being actually provided versus where the provider is registered. And so there may be a little bit of a disconnect between the geography there in terms of where the person is providing services, or if it's in multiple locations, and where they're assigned according to their MPI.
Yeah, that's certainly true. I think, the map that still shows primarily in that northern region of the lower peninsula of Michigan, where you see that very large gap in number of different types of providers and counties without a psychiatrist or without a psychiatrist and a psychologist. A lot of those counties are unfortunately clustered together. So there still certainly is an access desert that occurs within that region of the state. Although I would agree, folks can certainly travel. It's just a question of how does that then impact access if either provider has to travel in order to provide coverage in another area, or the individual has to travel to go and receive care. We'll also note that as telehealth ramps up in the data, as telehealth ramped up in 2020 and 2021, this issue around geography gets even more complicated. And there's been some really great work that's coming out of the University of Michigan. I know that's worked around some of these geographic and telehealth coverage issues, but it's a challenge from a data study standpoint, because the location that gets listed can sometimes be the patient's location and can sometimes be the provider's location. So it is kind of a challenge within a telehealth world to better understand of where that care is being provided and where those access gaps exist. But look for more of our work in that space in the future.
Mm-hmm. Yeah, we have a question on the extent to which uninsured in Michigan may in fact qualify for Medicaid. Yeah, and I don't know the answer to whether someone has looked at that or what the extent to which that is a factor in coverage for these services. I don't know if anyone else has any insights into that.
I think we're nearing the end of our questions in our time together today, but I really wanted to thank you, Ani and Corey, for providing a really insightful report and presentation and taking time to answer so many of our questions today. Thank you too for providing additional follow-up and contact information for both of you. If any of you have any continued questions around the methodology or results for Ani and Corey, I encourage you to reach out to them. I'm sure they'd be happy to answer those for you. I wanted to share with all of you that we will be posting these slides on our website, where there are additional materials related to the access study, including some one-pagers. And if there are any other ways that the Health Fund might be able to support you in addressing some of the access barriers that were identified here today and some of the proposed strategies, please feel free to reach out to our team here at the Health Fund. We stand ready to partner with each of you. Thank you again to all of you who joined us today. We look forward to continued conversations. Have a great day, everyone.